And then I'll introduce also Dr. Ellen Hillegass. She's an experienced educator, clinician, and a dynamic teacher. She's an adjunct associate professor in the DPT program at Mercer University, Western Carolina, and Touro University. She serves as president of cardiopulmonary specialists and is an instructor of continuing education programs across the country. She is a fellow of the ABPTS and has been very active in the cardiovascular pulmonary section in years past. She's also a fellow of the American Association of Cardiac and Pulmonary Rehab. Additionally, she's the editor of the Essentials in Cardiopulmonary Physical Therapy, which is being updated this year. I think that is it for our introductions, and I will go ahead and pass it over to Ellen. Welcome. I'm sorry. Yes, Ellen, sorry.
Thank you, Talia. Thank you for the introduction, and welcome everybody to this webinar. I know many of you are probably anxious at this stage, whether you're going to be applying for this coming year or even a couple of years. So both Morgan and I hope that you will breathe a little sigh of relief after listening to this and develop a plan for your studying, for your applying, etc. We also have some exciting news to present to you about some of the changes that are occurring to this application process. So I'm very excited to be here, and I truly appreciate the cardiovascular and pulmonary section for inviting me to be a speaker on this program. So what we want to do today is we want to talk about the American Board of Physical Therapy specialty requirements to be able to sit for the CC exam. We want to describe the process, including the application, sitting for the exam, and the notification of results. We want to talk about the different content that will be covered on the CCS examination. And at the end, we want to be able to comprehend successful strategies and resources for examination preparation. And I know that's what you all want. We do have a few disclosures, and I'm going to present both Morgan's and mine. Both Morgan, Johanson, and myself are actually involved in continuing education. Morgan is the president of what's known as Good Heart Education, and I am the founder and CEO of PT Cardiopulmonary Educators. Both are live and web-based continuing education companies. I also am the editor, and both Morgan and I and Talia are contributing authors to the Essentials of Cardiovascular and Pulmonary Physical Therapy, the 5th edition, which is in press now. And Talia has no disclosures to present. I need to actually also disclose a couple of things. This session is not sponsored by the ABPTS. It is endorsed by the Cardiovascular and Pulmonary section, but it is not sponsored by the Specialty Council. None of the speakers are item writers. We cannot write questions for the exam. This session has been created by both Morgan and myself and represents various ways that an individual might prepare for the exam. These are recommendations from us, and so you need to realize this is not from the section, but from us. There also have been numerous requests to the cardiovascular and pulmonary section and its members from people who wish to take the CCS exam asking for guidance, and that's what has created this actual webinar. But you need to realize that the opinions expressed in this session are not necessarily those of the cardiovascular pulmonary section of the APTA. So let's sit back for a minute. If you were taking the CCS exam, what is the cardiopulmonary area you would need to review and study the most? So go ahead and put that in your chat box, because you need to think about it, because that's what you should be working on when you're sitting or getting ready for the CCS exam. You should be working on what are your weaknesses, not what you do on a daily basis, but what you need to study the most. So we want you to think about that first and go ahead and write it out there. And I'll give you a second or two. All right, so let's go ahead and go through some of the information about the test. Why is the cardiopulmonary clinical specialty exam so challenging? That's because the test questions are not based on research, they're based on research articles, not just textbooks. So there's a lot of information out there. The exam is not geared for your highly specialized settings with cutting-edge, controversial treatments. It is geared towards the major medical centers with the commonly seen diagnoses. And we're going to talk about those commonly seen diagnoses towards the end of this, because you need to realize, where do you need to put your biggest bang for your buck? You don't need to be studying the most obscure diseases. And since the exam has already been written for 2021, when you sit for if you're sitting for the 2021, February, March 2021, you won't be getting questions on COVID. So you might as well not study COVID-19. You also need to realize that the exam covers cardiovascular and pulmonary content across all settings. So if you're in acute care, if you're in ICU, you need to understand what goes on in outpatient pulmonary rehab, what goes on in outpatient cardiac rehab, and what goes on in pediatric settings. You also need to understand statistics and research questions, because they are also on the exam. And sometimes these questions surprise people. Also, what you do in your daily practice may not exactly be on the test. You may have some clinical practice differences, and that may be because you're highly specialized or you have a different patient population. So if you rely solely on what you do in clinical practice, you will not have a very great chance of being successful in passing. You need to get outside of your realm and really look across the practice, from pediatric to geriatric, from all the way pulmonary, acute, ventilator, all the way to outpatient, acute cardiac, all the way to cardiac rehab. So you need to make sure that you cover all the different areas. And that's very important. Okay, so let's look at some of the specialization statistics. What are some of the statistics? Look at the specialty areas. Now, this is through 2019. In about 2 weeks, our people who took the exam in February and March of this year should be hearing. So this is not including those people. So up through those who heard last year, we have 349 cardiovascular and pulmonary specialists. That's very critical, okay? Not sure where this red line is coming from. It's now removed, thank goodness. But it's key to understand how we compare to the other specialists. So look at geriatrics, look at neurology, look at pediatrics, look at sports. Even women's health is above us. We are above clinical electro, and of course, no one is ahead of orthopedics. But that's always going to be the case. But we think cardiovascular and pulmonary is going to rise. Again, this is data through last year, June of 2019. Let's also look at where we have the most specialists. Massachusetts, thank God we had a lot in New York after COVID-19, and Illinois. Those are the 3 states with the most number of CCSs. And which are the ones with the least? So these are where we want to see more specialists grow. So it's very, very important to understand there's variance across the United States. And that's going to continue to happen, but maybe we can grow more in each area. Then people ask me, what are the benefits of specialization? New job opportunities, especially right now. We're looking for higher trained individuals to treat people in the ICU and the acute care because of what's going on now. I think we have the actual audience. They understand the need for us at the moment, cardiopulmonary clinical specialists. But we also have the opportunity to speak in a lot of places because they realize we are specialized in our areas. There's plenty of teaching opportunities. We have a very, very low rate of people who are teaching in the programs, a high number of programs and a low number of cardiopulmonary clinical specialists teaching. So there's great opportunities for teaching in academic settings. Leadership and service opportunities. You see a lot of CCS people take on leadership roles in their state, in the chapter, maybe even in acute care or other sections, geriatrics, and other service opportunities. We also have much more of a chance to do collaboration with research. We have much more networking opportunities because of our specialization. We often have a lot more opportunities to consult. And hopefully, we haven't seen a lot yet, but that there may be more financial benefits by being specialized. So what are some of the frequently asked questions that we see? First of all, people go, what is ABPTS? So let's talk about these different abbreviations. ABPTS is the American Board of Physical Therapy Specialties. It coordinates and oversees the specialist certification process. And it's actually the governing body for certification and recertification. So you will get to know the ABPTS. The ABPTS is made up of specialty councils of each section, and we do have a specialty council, which I think has 5 members of it. So what is the American Board of Physical Therapy Residency and Fellowship Education, ABPTRFE? This is actually the accrediting body for the APTA for post-professional residency and fellowship programs in physical therapy, of which there are some people who go through residency, and that's basically a fast track towards specialty, because if you go through a residency, you do not have to have the 3 years of specialty practice clinical hours. 1 year of residency is equivalent to the 3 years of practice in the specialty area. And so you can sit for the boards immediately following the residency if you meet all the other criteria. And then people throw around the abbreviation DSP. That's description of specialty practice. And that actually describes what are the advanced knowledge and skills required of PT specialists. So each specialty has a DSP. You need to get a hold of the DSP from the Specialty Council, and you need to understand what are the advanced knowledge and skills that are required, because that will help you when you're studying for the exam. So what are some other things that are required to sit for the exam? Applicants must hold a current, permanent, unrestricted license to practice PT in the U.S. or in the possessions or territories. So we can be practicing elsewhere. Applicants are required to pay the application review and exam fee, and applicants must meet the minimum eligibility requirements to sit in 2021 by the new application deadline, which is October 1st, 2020. This was extended due to the COVID-19 pandemic and all the things that have been happening to everybody. So the deadline is no longer July 1st of this year. It may go back to July 1st next year. So if you're looking to sit in 2022, do not rely on the October 1 deadline. That is for this current year only. Applicants must also submit a complete application and a review fee for each certification exam. You cannot use your hours in cardiopulmonary for different specialty areas. So you can only apply your your hours to your cardiopulmonary exam if that's what you're applying for. So here's the new information. First of all, option A is direct patient care hours versus option B, which is residency. So these are your 2 requirements. You either have direct patient care hours of 2,000 hours in the specialty area within the past 10 years, 25% or 500 hours have to have occurred within the past 3 years. And that can include multiple activities that, you can look in the actual application information, the candidate criteria, and find out how you can apply your hours that you've performed in multiple different settings or situations to get your 500 hours in the past 3 years and 2,000 hours in the past 10. And option B is you can submit evidence of having been in a clinical residency within the past 10 years. So A or B, not A and B. You also need to demonstrate that you have ACLS certification. But the new guideline for this year at the moment only, maybe not for 2022, this ACLS certification must be completed by 30 days prior to the exam test window opening. The exam test is going to start February 27th, 2021. So you need to have your ACLS certification by January 27th, 2021. So you have a little more time to get this certification. But the other thing that is brand new this year, not just date, but 2 different options for research. Option A, not option A of patient care hours versus residency, but option A for research. You can perform a data analysis project. You can submit a project that you've done. Remember, the deadline being October 1st. Or option B, you can do a case study, a case reflection. This is brand new. This is long awaited. And we'll talk about option B in a second. So, direct patient care hours or residency. And then of that, you need to also have ACLS certification and then some sort of research, case reflection, or data analysis project. So let's go to the age-old data analysis project, also abbreviated DAP. So if you get confused with abbreviations, just remember DAP is data analysis project. What you want to do is you want to present to the council evidence of involvement in the formulation and execution of a clinical data analysis project that is related to cardiovascular and pulmonary specialties. So you can go look up the different diagnoses. And as long as it fits in the cardiovascular and pulmonary specialty area, that evidence should work. But you have to show your involvement. The project also must be completed by October 1, and you must demonstrate dissemination. Now, dissemination means that you can have a continuing education program at your facility. You can submit an abstract for CSM, and if you're accepted, that could be the dissemination. But some way you have to talk about how you have given this information outside of just submitting it for the exam. So dissemination and completion by October 1. This data analysis project has to have been completed within the past 10 years. So it could have been some kind of master's or DPT project, but it couldn't be any longer than 10 years ago. There are lots of different projects that have been accepted. There have been quality assurance or quality improvement or utilization review projects, analyzing your current program, maybe your early mobility program, analyzing that, structured surveys, a systematic review, an actual clinical research trial. But again, go back to the first bullet point, which says you have to talk about your involvement in the formulation and the execution. So you can do lots of different things, but you have to show that you actually helped develop it and execute it. The project dissemination, again, can be conference presentation, can be a publication, can be a presentation or an in-service at your facility. So when you're thinking about a data analysis project, if you don't have one, consider ongoing projects that are already going on in your PT department. Can you jump on? But again, you have to demonstrate formulation and execution. You can look at the short and long-term goals of your PT department and maybe implement a quality improvement project. Look at various departments within your organization and maybe look at their short and long-term goals. Look at a PT perspective to be included in an analysis of service for your organization. Become part of a larger multidisciplinary or organizational project and bring in the PT perspective. Consider a quality of improvement project. Maybe take some data out of Epic or one of your EMRs and look at some information there and analyze the data. And on this slide, I'm not going to go through them all, but these are projects that have been done in the past, and you can review some of these as examples. And there are more examples that can be given to you if you need them in the future. So please don't be stifled by ideas. Now, this is where you all are sitting on pins and needles, and this is where Morgan and Talia and Angela and I are sitting here cheering in the background. We have a separate option. If we can't do a data analysis project, we now can do a case reflection. One case reflection needs to demonstrate specific specialty practice in cardiovascular and pulmonary physical therapy must be based on a patient or a client seen within the last 3 years. And there are specifics in the candidate guide. The purpose is really to document competency in the patient-client management in the specialty area. So the patient management in a clinical case should talk about clinical reasoning skills that demonstrate your competency in your specialty area. There are some guidelines for case selection, but you should be going through your case reflection by providing an examination, an evaluation, a diagnosis, a prognosis, and an intervention, which would lead to optimal outcomes of care. They recommend selecting a typical case in your practice, and the case should demonstrate cardiovascular and pulmonary specialized care. Now, I've also provided for you the actual rubric that is used for grading, and this is also in your candidate guide. So this is no surprise, and you don't have to, make sure you have this with your slides. It's also in the candidate guide. And this is a title, an abstract, keywords, an introduction, a timeline of the episode of care, the rationale, the purpose, and then the narrative of the case. And you go through examination, evaluation, prognosis, interventions, follow-up, and outcomes. So this is really your guts right here. And this is where you should be spending your efforts. And then there's discussion, post-case reflections, conclusion, references, acknowledgments, informed consent, and you use the format. Now, the Specialty Council didn't come up with this on their own. It came directly from the CARE guidelines, which have been validated as reporting standards for a case reflection. So you should be displaying, again, beyond entry level. You've got to be showing that you're a clinical specialist. You've got to be up on current cardiovascular and pulmonary research related to your case. You've got to be able to interpret any statistical findings, demonstrate generalizability of your case to a population, comparing that by using the literature, and synthesize all the information with rationale, appropriate rationale for using the interventions and for monitoring. So this should provide you a lot more flexibility if you're not able to do a data analysis project. Neither one is easy. A case reflection is not a cakewalk, but it is an option for those who can't do a data analysis project. And so one big hooray here, and thank you to the Specialty Council for listening to all of you who've been saying this is difficult for us to do a data analysis project. Now, I put this slide in here because you need to realize, not that you're going to have a rejection, but if you do have some kind of rejection, that you are told you're ineligible to sit for the exam based on your research or something else in your application, please appeal. Don't feel like you're not knowledgeable, you're not worthy. Please consider appealing. And you can appeal to the specialty council, but you have to appeal first to the council and within, I think it's 10 days, 2 weeks from the date of your denial letter. So don't feel bad for yourself for 4 weeks and then think about appealing. Write an appeal after your denial. And if you're again rejected, don't give up. Appeal to the actual board over the specialty council. And why do I say that is because there have been people that have appealed and have had success. I'm not saying everyone, but please remember you do have a right as an applicant to appeal their decision. And then you can appeal their decision. If they reject you the second time, you can go to the ABPTS board. So I just want you to know about options that are there for you. All right, deep breath, everybody. How would you rate your current anxiety about taking the CCS exam? Go ahead and let's throw this in the chat box. Do you find any of these words fit you? Irritable, restless, worried, agitated, high heart rate, sweating, feeling nervous. Any of those feel like you at the moment? Or maybe after I've just told you about this case reflection, you're going, yay! And you now have a heart rate of 55. So anyway, I just want you to know it's not an easy process, and we know it's not an easy process, but we're here to tell you there are people to help you, okay? So let's go through the application specifics. There's a deadline. Remember, it's not July 1st this year. Future years may go back to July 1st, but this year it is October 1st. So what happens is that the program staff reviews the applicants, and it can take up to 6 weeks. So we're talking mid-November, all right? And so if it's publicized and it's in the candidate guide is 6 weeks, if it's 7 weeks, contact them, because you have written definition that says they should be doing it in 6 weeks. So contact them and say, hey, I'm just wondering, you got my application, I haven't heard, wondering when I might hear, okay? And then make sure everything is good on your application. Make sure if you've gotten married, you've made sure you've changed your name, make sure your application matches your ID that you'll use in your testing center. If you get married between October and February, make sure your ID matches what's going to be going to the testing center. These are very critical things, and you may laugh, but it makes a difference. Now, another thing is that they have not changed the fees since 2019. The fees do have to be in with the application on October 1st, $525 for APTA members, non-members $870. If it's a reapplication, $170. They've actually said you can make 2 installments on your fees because they realize that COVID-19 has affected everybody everywhere. All right, and so these are key things to understand about the application process. The exam fee is submitted after you're notified that you're able to sit. So you have to give an application fee first, and then once they tell you that you can sit, then you have to pay another fee, and that's to sit for the exam. That fee is $810 for an APTA member, non-APTA $1,535. It's kind of worth it to join the APTA. But that fee doesn't have to be in by October. That second fee can be received by December 28th. Then after they receive that fee, then they will give you information on how to access and download your electronic scheduling. So you start scheduling when you're going to take the exam. If it's 2021, it's between February 27th and March 13th. For those interested in 2022, we don't have that window yet, okay? So keep that in mind. And you will be taking the exam at a Prometric testing site. And that's once they've gotten your exam fee, etc. Let's say something happens and you're unable to sit for the exam. Just notify the council. Make sure you let them know. And when you're going to your test, make sure you arrive early. Don't slide in there a minute or two before the exam. Get there 30 minutes early just to make sure. The exam is entirely on the computer, so if you are not used to computer exams, you need to get prepared. You need to practice, okay? They actually watch you via video and audio while you're taking the test. You need a picture ID that has your signature. Nothing else goes in. Okay, they give you a board that you can scribble things on, but you can't bring in any paper or anything. So everything else is left in your locker. There are 200 questions over a 7-hour time period, and you're allowed to take them at the rate you want to. So there's first a tutorial, and then there's 4 1.5-hour test periods. If you get done the first test and you don't feel you need a break, then you can go on to the second test. Recommendation are, though, go ahead and just take a 5 or 10-minute break, walk around, breathe deeply, get something to drink, something to eat. You don't have to take your full rest period, which is up to 50 minutes. But it might be a good idea just to clear your head before you go in for the second or the third or the fourth. If you finish a section early, you can't use that extra time onto the next section, okay? So just keep that in mind. And so it doesn't hurt to take breathing and walking around breaks just to clear your head when you're actually taking the tests. Now here's the funny thing that everyone wonders. Gosh, I took the NPTE and I heard right away. Not with the specialty exam. So what happens is everyone has taken the exam this year by mid-March and they still haven't heard. And they won't hear until the next couple of weeks. So the ABPTS meets after the exam, usually sometime in May, and they make decisions on the results. And these are given to you via an email in mid-June. Only to you, and they do not announce to anyone else if you didn't pass. That is totally, kept confidential. So it's up to you to say whether you took the exam and whether you passed or whether you didn't pass. It's not up to the ABPTS, but they will notify you by mid-June. Your score report comes back and you get an exam score. You get a passing score on the exam and feedback on your performance, and this is a scaled score, okay? During this period of time, they are doing validation and item analysis, etc. But keep in mind, this is all confidential. So if you don't want to tell people that you're taking the exam, don't tell them. And then you don't have to tell them whether you didn't pass or not. It's up to you. This kind of got crazy in changing from Google Slides to PowerPoint. So I'm just going to, if you see these kind of varying 4%, 10% everywhere else, it's because of the change. But so what is the percentage of exam questions? Professional behaviors, leadership, education, and administration are only 10% of the exam. So don't get too caught up in some of that area. Consultation, 4%. Evidence-based practice, 10%. History taking and systems review, 10%. Different tests and measures, 10%. Evaluation, analyzing, interpreting, diagnosis, prognosis, and outcome determination, about 30%. Interventions, 12%. Foundational, clinical, and behavioral sciences, 14%. So look at where the emphasis is. It's what you typically do on a daily basis. So it's not outside your realm, it just the different diagnoses may be outside your realm. So that comes down to if that's what the test is involved, what's your study plan? Figure out a study plan. Figure out when you're going to study and when you're going to take breaks. But before you start studying, you need to really assess yourself. And you can do that with a mentor or without a mentor. What you want to do is what are my strengths? Okay, if those are my strengths, what are my weaknesses? Okay, that's where I need to be concentrating my time, on my weaknesses. Okay, if I do this on a daily basis, you shouldn't be working on that as much. You should be working on things that you don't do on a daily basis that are your weaknesses. Break down your topics on the calendar. This day, I'm going to study pediatric pulmonary. Next Tuesday, I'm going to study pediatric cardiac. So plan to study each week, not every day, but figure out that you want to digest this material and really know it. So it takes longer than a week or two before the exam. We can't really cram this stuff. So you really need to start studying earlier. Now, some people may have scooted through, school, not had a problem because they had easy tests or they test well or whatever. But other people had trouble. And so maybe if you had test-taking challenges in DPT school, maybe you need to get some help in test-taking. So test-taking strategies. And particularly, you want to be able to discriminate between two answers that are very close, because that's what it usually comes down to. 4 possible answers, but 2 answers that are very close. You might also look at this and say, maybe I need a lot longer time to take tests. Maybe you need to be tested for special accommodations. And others may not have been used to taking tests on computers. So that's what you need to practice. Practice taking tests on computers, because that's how you're going to take your test. Now, I wanted to throw in here also that we do have residency programs that are options if this is something in the future. So you could also potentially do residency and go to any of these residency programs. And remember, that's a 1-year program, and then you can sit for the exam after that. So these are your accredited residency programs, and this is your candidate program. University of Miami is taking patients, but they're considered to be in candidacy status as far as that goes. So keep in mind that's another opportunity for you. Excuse me, I'm sorry. There are pros and cons of residency programs. It's a fast track to specialization. You have guaranteed clinical mentoring. And actually, residents have a higher chance of passing the boards. They have 15% higher chance of passing the boards, because what have they had in residency? They've had clinical mentoring in other areas besides clinical practice, and they can also do their research there. So this is one thing that you may be missing. So you may be looking at trying to get some kind of mentoring that would help you. If you're not going to go through residency and you want to sit for the exam and you feel you have some weaknesses. The cons to doing residency program is that it's easiest to do right after entry level, but it's not always something you want to go back and do after you've gone out into practice. You often don't get paid a full pay as a resident, but you often do get benefits as far as that goes. We can talk about starting residency programs. You can email me specifically and I can help you understand about starting residency programs after that. So I'm going to now take a break and ask you, do you feel like you have a better idea of how the exam works and what you can expect? So I want you to put in the chat box, yes or no. There's no maybes allowed this time. So let's see if we've got an idea. And then what I'm going to do is I'm turning the rest of the program over to Morgan. And you are in great hands with Morgan, because she knows also all about this process and about helping people sit for the exam and to be mentored. So Morgan,
Okay, can you guys hear me? Ellen, can you hear me? Okay, we hear you. Great,
Yes.
excellent. Okay, thank you for that wonderful introduction, Talia and Ellen. I'm also very excited to be with you all this evening. So I'm going to switch gears and sort of talk about how to study and resources and other things that you can do, textbooks, etc., that can help you prepare. And one of the main things that you want to do right now, today, is make sure that you have a dedicated cardiovascular and pulmonary physical therapy textbook. Now, there are many in print. These are listed in by date of publication. And it is important to remember that the test is kept up to date. And so if you're using a book from 2009, it may not, or from 2004, it may not be up to date enough for what the material is that you're seeing on the exam. So you do kind of want to be in, you know, some of these higher, closer to now date of publications. But there are numerous people that have taken all of these textbooks and had success on the exam. Next slide, please. In addition to the dedicated cardiovascular and pulmonary textbook, there are other textbooks that we consider extremely useful, especially for outpatients, okay? A lot of us work in acute care, ICU, skilled nursing facility, but for those folks who are not in outpatient, the knowledge base that you are going to be tested on for those settings is sometimes hard to know what to look at or to look for. And so there's two textbooks. There's one called the Guidelines for Pulmonary Rehabilitation, and actually we're on the fifth, that should be corrected. We're on the 5th edition now, so get the 5th edition. And that is for outpatient pulmonary rehab. Excellent resource. And then Guidelines for Cardiac Rehab and Secondary Prevention Programs. Again, that's the 5th edition that we're on. And that is for outpatient cardiac rehab programs. And you need to read those books cover to cover, just like reading the physical therapy, cardiovascular, and pulmonary textbook cover to cover. Then another resource that is really great for what is considered a normal vital response. Obviously, hemodynamics are going to be all over this exam because the cardiovascular and pulmonary systems, we have to have a great understanding of what the hemodynamics are when they're at rest, when they're working. Is that change normal? Is it abnormal? If it's abnormal, what should I do with that? And so if you don't have a good basic understanding of what is normal, what's considered abnormal, and what are the possible reasons why it's abnormal, then you're not going to really be able to do the clinical reasoning through the cases. And so Guidelines for Exercise Testing and Prescription by ACSM and is just a great resource. Then there's some other textbooks listed here. Acute Care Handbook for Physical Therapy, that's Paz and West, and a lot of people use the cardiac section of that book. Exercise Physiology, there's numerous books out there. This is just one listed. And then for the research stuff, because you will have specific questions about, you know, research study design, level of evidence, which statistical test is appropriate given which type of data. And to understand those kind of things, there's 3 resources listed here. A lot of people use their National Physical Therapy Exam study guides from their DPT when they finished their DPT program and was taking the national exam. So that still applies. So you can go back to your study guide if you still have it and start there. Diane Jewell's textbook is excellent because it's specifically geared towards physical therapy practice. And then this other textbook here by Moore has a lot more to do with statistical tests and why certain things are important in statistics, like bias and sampling and that sort of thing. Okay, next slide. All right, the key to success on this exam is asking questions to somebody who has already taken the exam. And so there's numerous ways to do that. You can find a mentor. Finding a mentor means seeing if anyone in your clinic has their CCS, and if they do, ask them if they would be willing to help you navigate your way through this process. If you have friends from physical therapy school or friends from other jobs that you know have taken the exam, call them up and ask them if they'd be willing to help. If you don't have anyone in any of those areas, contact someone on the listserv. I know as professional development chair for the cardiovascular and pulmonary section, I know one of the things that we're currently working on is trying to come up with a database of people in every state that are willing to be mentors. And so hopefully we can have that up and rolling soon for people. So contact us on the listserv. Somebody asked in a chat, is there a CVP self-assessment tool? Yes, there is. I'm going to go over it in a second. Ellen and I have listed both of our education companies here. And again, we put that out as a disclaimer, but we both mentor people with online and recorded and live webinars and mentoring. And so you can go to our website to see what our various services are. Another great thing is the American Association of Cardiovascular and Pulmonary Rehab has an annual conference. Now, this is the group that certifies outpatient cardiac and outpatient pulmonary rehab programs. And this is a group of individuals made up of researchers, physicians, surgeons, hospital administrators, RTs, PTs, OTs, exercise physiology. It's a great group of people where you get a lot of diverse information, and they have a great conference every year. You can also attend CSM, and there's cardiovascular and pulmonary specific section programming, and a lot of times there are excellent lectures that directly apply to preparing for the test. And a lot of people email me before CSM every year saying, you know, which sessions do you think would really help me for the test, and we can help you pick through some of them, especially if there's two that you think might be, and you're trying to differentiate which ones to go to when they're offered at the same time. And then we also have pre-conference courses sponsored by the cardiovascular and pulmonary section. And I know that the course that is being proposed for next year, although we don't have the official word out yet, we do know that it's going to be an excellent one for prep. So look into that. All right, next slide, please. Okay, here's the example of what the self-assessment looks like, okay? And you can go to the cardiopt.org and download this form. And if you're having trouble finding it, just email me because I have it in my computer. But basically, it asks you a bunch of questions, and it gives you the ability to say unsatisfactory performance, satisfactory performance, superior performance, etc. And when you're writing this, it's your assessment of where you personally think you stand in that area. And some of the things are general, but then as you go through the document, you'll see that they'll get more specific. And so everywhere where you put an unsatisfactory performance, that's the area that Ellen was talking about earlier. That's your area of weakness. And that's the area you should be studying the most. If you think you're doing great in that area, maybe you review a couple things, but that's not where you spend your major amounts of time. Okay, next slide. There's a ton of continuing education courses out there, okay? And to find them, I've listed, so when I went through continuing education companies out there and looked at their cardiac and pulmonary rehab content, if they had courses that looked like they applied to the exam, I put them on this list. There's one company missing from this list, and that's MedBridge. MedBridge should be on here. They have a lot of cardiac and pulmonary courses to offer. And so, again, you're usually being taught by a cardiovascular and pulmonary expert if you're choosing a cardiovascular and pulmonary course. Not on this slide. Ellen and I do a course in October and a course in January that is specifically designed for cardiovascular and pulmonary exam preparation. And so if you're interested in finding out about that course, you can email us and we will give you the details. Next slide, please. Then the ABPTS offers a study guide, or excuse me, a study group. And there's a question box on your application, and it asks you, if you want to participate in the study group, please answer yes, and you check the box yes. If you don't check the box yes, they will not send you the information and contact information of your peers that are also studying for the exam. So what this means, if you check the box, it means that you're telling everyone else who is sitting for the exam, who wants to participate in a study guide, you're giving them access to your name and your email address. And then you can contact, the ABPTS will send you a list of those people once they know who all's been approved to sit for the exam. So that will be after October 1st, 6 weeks after October 1st. And then they will basically tell you who is also sitting, and you can contact those people and see if they would like to study with you. We also have developed a CCS study guide by the cardiovascular and pulmonary section. It's a great resource, and we will be selling it. There is one price for APTA members, and there's one price for non-APTA members. And it will be available on the cardiovascular and pulmonary website. So that's the cardiopt.org by summer 2020. So we're hoping to get it up by August, September, so that you guys can start going through that. And then there's also a mentoring face group page, right? And the Facebook page requires access, so you have to, contact them and ask them to join. I recommend that you do that because Talia runs puts a lot of information out on that Facebook page, as does Ashley Parrish. Ashley Parrish is our public relations chair, and she is constantly putting information out to you guys via Facebook on CCS information when it comes up. So it's always good to have that resource available. Okay, next slide. All right, so can you answer this question now? Do you feel like you have resources that can help you now prepare for the test? So go ahead and put what you think is your answer in that chat box. I'll give you a couple seconds and then we'll go on to the next slide. Okay, so this is the DSP content. Every 10 years, we just approved our new DSP, so that should say 2019 there. We just approved it, so every 10 years, a new DSP comes out. And when you apply for the exam, if you are approved to sit for the exam, you will automatically be sent a DSP. If you don't want to wait till October to get the DSP, then here's the web URL where you can buy one. Keep in mind that it's free when you are approved to sit for the exam. So if you're getting it early, you're going to have to pay for it, and then if you get approved, you'll get it again later. So you may not want to buy it yet, unless you're one of those people that's thinking about taking it maybe in 2022 or 2023. I think it's $25, so it's not a huge expense. It breaks down the different sections on the test. So it talks about research, administration, education, the patient care, the consultation, and you can use it as sort of a checklist for your studying. And then we basically have to come up with what is the curriculum of the cardiovascular and pulmonary content that's considered entry-level DPT knowledge, and what part of the curriculum is considered specialty practice. And so that's one of the things that the DSP helps you differentiate, okay? Because it's going to show you the diagnoses that that are commonly seen, rarely seen, and occasionally seen. Okay, next slide, please. All right, so here's some examples of those cardiovascular diagnoses that are frequently seen. So when you're looking down this list, if you don't see patients with these diseases, then you need to go from soup to nuts with each of these diseases. So atherosclerotic disease, what's the anatomy? What's the pathophysiology? What's the diagnostic testing for that disease? What does the diagnostic testing results mean? How does it guide the doctor's medical interventions? Okay, so what are the medical doctors doing about this problem? And then what are the physical therapists doing about this problem? What are the physical therapy evaluation and exam techniques that are needed to treat somebody with atherosclerotic disease? What are the ways that we're going to provide interventions, and how are we going to progress those interventions, and how are we going to monitor those patients with those diseases? And what are the outcome measures that are statistically reliable and valid in that patient population? What are some of the teaching techniques that we need to be aware of, not only when we're teaching patients, but the greater public and DPT students or other physical therapy colleagues? And so you need to go through that process with each one of these diseases and know it forwards and backwards, okay? The commonly seen diagnoses are all over the test, okay? And here, there's 2 slides here of them. Now the next one, go ahead, Ellen, to the next slide, is the pulmonary diagnoses that are frequently seen. So you need to do the exact same thing with these pulmonary diagnoses and go through each one. And I think there's 2 slides of frequently seen pulmonary diagnoses too. And then the next slide, what you'll see is there's occasionally or rarely seen diagnoses, okay? Now these type of patients may come up on the test, but they're not gonna ask as detailed questions about them because they know that you don't see them often. So they may ask, like, let's say it's a tetralogy of Fallot, which is a congenital defect in the heart. They may ask an anatomy question about that. Or they may ask, is this a cyanotic heart lesion or an acyanotic heart lesion? And so understanding how the blood flows through a normal heart and what happens if it's abnormal anatomy, and understanding if that blood has oxygen going to that baby. And so they may ask more of a question like that instead of the precise treatment procedures that are going to happen with those diagnoses, because we all don't see them very often. Okay, so those type of questions will show up, but as long as you've studied the basics, you should be able to answer the questions of the rarely seen diagnoses. Okay, next slide. Okay, so now we are going to take the next, so it's 8:30. We want to make sure we leave time for questions. So we're going to stop at 10 to 9 and with questions. So we're going to try to get through as many case studies as we can, okay? These are sample questions, and keep in mind that the test is almost entirely written in case study format. And I think Ellen would agree that that's the biggest thing that people tell us when we're helping people study for the test, that it threw them off because the questions required a lot of reading. And on the NPTE exam, you were asked a short question and given recall answers, meaning they asked you, what is the normal blood pressure response if a patient increased their metabolic equivalence by 3 mets? And then they would give you choices. You only have to understand when you're reading that question the blood pressure response. When you're reading a case study, you have all of the areas that you've studied in one question. You have anatomy, you have physiology, you have pathophysiology, you have the diagnostic testing and what those results were. And you have to analyze all that in order to answer the question. And that can often throw people. So, you know, here's some example test questions, and hopefully you can get an idea of how they're going to ask these questions. Okay, so the first question is, 72-year-old male who was admitted for a CHF exacerbation. He's complaining of increased fatigue, shortness of breath at rest, and dyspnea over the last couple of weeks. Yesterday, he couldn't walk upstairs to his room and had to sleep on the couch. He attends his anticoagulation clinic appointments regularly, but he reports that he has been having frequent nosebleeds and states that his INR values have been increasing. His past medical history includes a previous MI, he had a Cabbage ×4, he has hypertension, he has atrial fibrillation, diabetes mellitus, dyslipidemia, benign prostate hypertrophy, and hypothyroidism. So we're not going to be testing you on benign prostate hypertrophy. It's not in the DSP for our specialty. And so don't worry about, when you're reading past medical history, don't worry about diagnoses that aren't cardiovascular and pulmonary. Just throw them out. Again, they will list the medications. If there's medications like, you know, Synthroid or other medications that aren't cardiovascular and pulmonary necessarily, you may not need to pay attention to them. So his medications are lisinopril, Coumadin, Carvedilol. I'm so bad at pronouncing medications, so excuse me if I mispronounce some of these. Alfluvacin, Synthroid, and Rovastatin calcium. His vitals, heart rate 61, respiratory rate 23, blood pressure 84/62, SpO2 on 2 liters of oxygen with a nasal cannula is 93%, and temperature is 99.2. Go ahead, next slide. Okay, this patient is most likely taking lisinopril because it acts as a diuretic, reducing preload and decreases blood volume, which reduces blood pressure. B, it acts as a phosphodiesterase inhibitor, increasing intracellular cyclic AMP content in cardiac muscle, which increases contractility It acts as a calcium channel blocker, causing vasodilation of the arterial vascular bed, which reduces the afterload, acts as a diuretic in decreasing preload, which increases stroke volume. So what do we think is the answer here? Now, if you don't feel comfortable, you don't have to make a guess in the chat box, but if you think you know, go ahead and make an answer. The answer is actually A, okay? And a lot of people know that lisinopril is an ACE inhibitor, and you would be right. And ACE inhibitors, which most people learn in DPT level, are great vasodilators, excellent vasodilators. But keep in mind that drugs have multiple actions on the cardiovascular and pulmonary system. And for the specialty exam, you need to know what the drug does in all aspects. And so remember that an ACE inhibitor is going to prevent the angiotensin-renin cascade from occurring. And the downstream consequence of that is to decrease fluid retention. And so by decreasing that fluid retention and eliminating the body water, your blood volume is going to come down, and that's going to help reduce your blood pressure as well, okay? And so this is a classic example of a question where they're going to ask a med question that may have a deeper level of knowledge than what you learned in DPT. Next question. Okay, sorry, I just increased anxiety. We're not trying to, but that obviously shows you that that might be an area, you know, put pharmacology down today. You need to start studying those meds today. Okay, so patient's lab values. Okay, so this sample question applies to our same case. Usually on the test, they'll give you one case and like 3 or 4 questions that go with that same case. Okay, so we're still talking about our guy. He's here with heart failure. His lab value today are as follows, okay? INR, 4.1. BUN is high, creatinine is high, glomerular filtration ratio is low. His liver lab, AST, ALT, bilirubin, all high. Troponin, not that bad, not ruling in for MI, but look at that BNP, definitely high for somebody with heart failure. Platelets are low. Next slide. Which statement describing the pathophysiology best explains the reason for this patient's frequent nosebleeds and high INR? A, decreased cardiac output results in decreased blood flow through the hepatic artery, causing liver dysfunction. B, cirrhosis resulting in portal hypertension, causing variceal bleeding. C, increased portal venous pressures, causing splenic congestion, resulting in thrombocytopenia. D, hepatic congestion, inhibiting warfarin metabolism. Okay, so remember that Coumadin and warfarin are the same drug. Okay, one was a brand name and one is a generic name. And he is on Coumadin. And remember that he has congestive heart failure. And when congestive heart failure is biventricular and backs up into the liver and affects the liver, it's called hepatic congestion. And when the liver is not functioning appropriately, drugs that are metabolized by the liver are not cleared through the body correctly. And warfarin is a classic example of one of those. So a lot of our patients who have atrial fibrillation will be on warfarin if they have heart failure in addition, and they go into a heart failure exacerbation and their liver starts failing. They're not going to process that Coumadin, and they're going to be at risk for nosebleeds, bleeding in their stool, bleeding in their brain. So the answer here is D. Okay, next question.
First, Morgan, I'm going to jump in here because there was a question related to this question. On the test, are we able to see the original case when going through the associated questions?
Good question. Yes.
Okay, thank you.
Yes, you can. In some cases, you have to go back a screen, but in other times, the case is small enough that they can carry it over. So it kind of depends on how long the case is. And also keep in mind, Ellen told you you're going to be allowed to bring in a scratch board with a dry erase pen and eraser. So you can write down, bullet points for the case on your scratch paper. Okay, so remember this patient has hypothyroidism in his past medical history. How is that directly contributing to this patient's heart disease? A, is it increasing the thyroid hormone levels, which is increasing his heart rate and decreasing his cholesterol? B, is it a decreased, does hypothyroidism mean decreased thyroid hormone levels, decreasing his heart rate, increasing his cholesterol, and increasing fluid around his heart? Is thyroxine a diuretic? And decreased metabolism leads to weight gain. So I'm seeing that people are already starting to put in answers, and B is correct, okay? Hypothyroidism means that it's a decreased thyroid level, and when your heart rate or when your thyroid levels are low, your heart rate's going to be low. It also has the effect of increasing your cholesterol, especially your LDL cholesterol. And it also increases fluid around the heart. So in somebody who has heart failure, hypothyroidism is going to exacerbate their heart failure. Okay, next question. Okay, case study number 2, we're going to do a lung case. 55-year-old male with end-stage lung disease, secondary to idiopathic pulmonary fibrosis, referred to physical therapy due to increased shortness of breath. He's on 3 liters of oxygen at rest and 10 with exertion. Previous medical history includes congenital cardiac disease with a repaired ventricular septal defect at age 5. Following surgery, he developed complete heart block and has had multiple pacemakers. He denies chest pain, palpitations, or syncopal episodes, but he reports feeling dizzy when he begins an activity. This resolves when the oxygen liter flow is increased. He also has hypertension, hearing loss, tremor. He was a smoker since age 18 with, smokeless tobacco, e-cigarette use, and no passive smoking exposure. The patient has had influenza and pneumonia vaccines this year. So he's being evaluated for lung transplant. Next slide. The changes typically seen on CT scan for idiopathic pulmonary fibrosis are A, a flattened diaphragm, B, tracheal shift to the left, honeycombing, or lung hyperinflation. And so here's an example of a question of how you have to understand how they use diagnostic testing for specific diseases and what we expect to see in the results for those specific diseases. And a lot of people are getting this right. C is the answer. Flattened diaphragm and lung hyperinflation are usually seen with obstructive lung disease, and idiopathic pulmonary fibrosis is a restrictive lung disease, so you'd be seeing low lung volumes instead of lung hyperinflation. And tracheal shift is usually seen with, a pneumothorax. And so there's nothing about this case that would indicate that this patient has a pneumothorax. So that's a perfect example of don't read anything into the question or the case that isn't there. I always tell people, don't take the patient that you saw last week into the test with you because the case study that they're asking you about, even though it might be similar, It's not the same, okay? And so don't read anything into the question that isn't there. So the answer would be C here. Okay, next question. Okay, same case study. Now here's the pulmonary function test. So we did FVC, FEV1, FEV1, FVC ratio, residual volume, total lung capacity, and DLCO, so the diffusion of carbon monoxide. And we tested that pre-bronchodilator and post-bronchodilator. And let's look at the predicted columns, okay? So anything below 80%, remember, is going to be decreased or abnormal. So FVC is still normal. FEV1 is decreased, okay? The FEV1 FVC ratio is still normal. Residual volume, that's decreased. Total lung capacity is decreased. And the DLCO is decreased. Next slide. Referring to the pulmonary function test results, and again, on the test, you would be able to see those results in front of you, okay? Which of the following predicted value is not typically seen in idiopathic pulmonary fibrosis? Okay, DLCO. Do these patients have diffusion problems? Is the FVC with these patients usually normal? Is the total lung capacity usually decreased? Is the residual volume usually decreased? So going back to, thanks, Ellen, you anticipated my needs here. Okay, so the FVC is normal. Okay, and remember that in restrictive lung disease, the FVC and the FEV1 FVC ratio are usually normal. Okay, now here, the FEV1 is decreased. And sometimes you see that in restrictive lung disease, but when the FVC and FEV1 are this drastically different, you could never have a normal FEV1 FVC ratio, right? Because these numbers, in order for this number to be close to 1, right, or close to this is actually a percentage, so there's a decimal point here, it's 0.84. When you divide 43 by 90, you're not going to get 84. So there's an error here in this table. Okay, total lung capacity in restrictive lung disease always goes down. DLCO always goes down in idiopathic pulmonary fibrosis. Residual volume doesn't usually change that much. Okay, so this is a real decrease here. So let's go back to our answers. Notice that FEV1 FVC and FEV1 alone are not answer choices. So the only one here, I'm not sure why we have a red scribble. I probably did that not knowing I did it. The only answer here that's obviously wrong is the residual volume one. We don't have restrictive lung disease, we don't have obstructive lung disease, and so we wouldn't necessarily anticipate seeing a residual volume change in this patient. Okay, next question. I know she's trying to advance the slide, but it's not working here. Okay, there we go. Okay, signs and symptoms of idiopathic pulmonary fibrosis include difficulty exhaling air. No, that's usually an obstructive problem. Digital clubbing of the fingers and toes. Decreased distending pressures. Inspiratory crackles at the bases. Okay. So remember when Ellen said that you have to be able to discriminate between answer choices here. I see two answers. B and D could be possible. Now, one of the things that you want to consider with digital clubbing is that that is something that takes years to form. And a lot of times, patients with idiopathic pulmonary fibrosis don't necessarily have it for years. They don't have cystic fibrosis in which they were born with. They haven't been a smoker for 50 years, so they've been living with COPD for that long. What patients with idiopathic pulmonary fibrosis have difficulty doing is inhaling fully and taking deep breaths. And so they don't fill air into their most distal or proximal air spaces of their lungs. So one of those areas is gonna be your bases. And remember that inspiratory crackles means that those collapsed airways, those airways that are not filled with air, are popping open and crackling as air is trying to descend down into that area. And so you will always hear crackles with IPF patients. And so D is a better answer than B, okay? So here's a perfect example of that discriminating stuff, okay? All right, next question. All right, here's some research and admin type questions, but I'm realizing it's 8:54. So what we can do is let's turn to some of the questions, and then you guys can read through these questions on your own, and if you don't know the answer, feel free to email us. So Talia, do you want to take over with questions?
Yeah, actually, we don't have too many, but there are a few.
Okay.
Let's go back to the data analysis project and potentially the case study too. Here's the question. I heard there was also potentially a request for more information, which is not an actual denial. Is that like an appeal? So
no.
Go ahead, sorry.
Yeah, so that's not asking you to appeal. Sometimes, like that happened to me when I filled out my application. They accepted my research project, but they weren't clear on how I disseminated my results. And so they asked me to submit proof that I had done my in-service. And so I had to then send them the slides of my PowerPoint and the sign-in sheet that said the printed name, signature, and title of all of the people that attended my in-service. And that was sufficient. And then they sent me my approval to sit. So when they're requesting additional information, they're not saying you're denied. They're saying that they want you to answer this question. So it behooves you to answer it immediately. And usually they give you like a time frame, but you want to answer it right away. And then it goes back to the specialty council and they look at your application again, and then you will be told whether you're approved or denied.
So Morgan, in the past, there have been people who have had things not where it's clarification, and I would say exactly what you said, that was clarification, but they've been told that either their project was not sufficient and it's denied based on the project unless they could give a different project, or denied because the project didn't have cardiopulmonary patients. And so denial is actually written in the letter, not could you clarify the information.
Good point.
Okay. Good point. That's true. I actually had the same thing happen, and I had 10 days to get, it was a very similar scenario that Morgan had. So, and the word denial did not appear in the initial letter. So absolutely. Let's see, there's some stuff coming in. I do not see the case study option on the ABPTS website. Is there somewhere else we can go to reference the criteria?
Yes, it is in the
Candidacy handbook.
candidate guide, and the candidate guide is now out.
Okay.
And that's on the website.
You can begin your application for the 2021 test now. Just because it's due October 1st doesn't mean that you have to wait to apply. If you have met all the criteria or you want to start gathering the information, because I mean, it's several pages long and you're going to have to answer all the questions. So if you want to go ahead and download the candidate guide, that I advise, and start looking at it and start, you know, formulating your answers to the questions, because that's going to tell you whether or not you have, like, you don't understand something and you need to contact us, or you have to contact your supervisor and make sure they're willing to verify your hours, things like that.
So Morgan, while you're on that, there is a question in terms of hours. Can I use a resume? And no, you have to actually document your hours.
Right, and your
Where
boss
they
has
were,
to
what
has to
year,
verify.
etc. Yeah.
Yep.
Okay. Does the data analysis project mean that you have to do statistical analysis with the data, or can the data be a collection from the EMR, comparing that data after the implementation of whatever project? So a before and after in the EMR as a QI project, or actually statistical analysis of the data?
I'll jump in on that if you don't mind, Morgan. So
Sure, go for it.
they want to see you analyze data. It may be means, t-tests, something simple. It doesn't have to be huge multiple ANOVA, you know, regression analysis or whatever. But they do want to see data analyzed. So it could be means and standard deviations, simple things that you can actually do with an online statistical analysis. And there are many, many data analysis projects that use data from EMR, but you have to analyze the data. So you actually have to have some kind of statistical analysis and then some kind of interpretation of it. If you can't do this on your own, I highly recommend you connect with your local DPT school and ask them if they could help you. And what typically happens is that they would love to help you and they can be a second author on a publication.
Okay, thank you. And then just a follow up to that, how old must the data analysis project be to be eligible? I think that was 10 years. Those projects must be done within the last 10 years. I just wanted to follow up there. In terms of the setting, there was a question about, does it matter which setting I get my hours in? Is it acute care versus outpatient cardiovascular or pulmonary rehab? And I don't think it matters.
It doesn't matter. If you have only practiced in the acute care ICU, or you've only practiced in skilled nursing facility, or you've only practiced in home health, it doesn't matter. What matters is that they're cardiovascular and pulmonary patients. So if you say you're seeing all ortho patients, then they're going to be like, that's not going to count. So you want to make sure that you're counting your cardiovascular and pulmonary patients. And like Ellen said, in the page where you're listing your hours, it tells you in there what all counts. And you will be surprised that a lot of things count, that it's not the same as Medicare rules for direct patient care. What they're saying is, did you work on this patient? So things like being a CI and overseeing your student treat a cardiovascular and pulmonary patient, those hours count. So keep that in mind. And then the reason why you have to study other sections or other settings is that perfect example of, if you've only been in the ICU, you don't know what you don't know about home health, and outpatient cardiac and pulmonary rehab. And you really need to study those areas. If you've only worked for adults, you don't know what you don't know about pediatrics. And so you really need to study pediatrics because those questions will be on the test. You don't have to treat pediatric patients in order to be eligible for this test. You could only have treated adults and still be accepted.
Thanks, Morgan. Ellen, do you have anything to add there?
No, it really does not matter where you have your clinical hours. And it doesn't matter if it's multiple facilities. But what they want to know is, so if you worked in multiple facilities over 2 years, you need to say how many hours per week you got of cardiopulmonary experience in each of these facilities. And you don't even have to spell out the facilities. You can just say, you know, I had 10% cardiopulmonary patients for these 6 months, or I had 90% were cardiopulmonary patients for these 6 months. And then you can just list your facilities. But you may be only in one facility, and that's fine. They just want to see hours in cardiopulmonary.
And you can go to that DSP to remind yourself of what patients count. Because if a patient was on a ventilator in the ICU for liver failure, that patient counts. They have an active pulmonary problem on their active medical problem list. So that patient counts. Even if they're there for, you know, being evaluated for liver transplant. So their biggest problem is their liver. They have an active pulmonary problem that makes them a cardiovascular and pulmonary patient. So keep that in mind too. It doesn't have to be, you know, all cabbages and all valve replacements and all heart failures. It can be some of these other patients that have, you know, like a stroke patient that has a comorbidity of dysphagia leading to massive pneumonia and intubation because of respiratory failure. That patient counts.
Okay, thank you all for clarifying those things. To pivot a little bit to the residency for just a second, there was a question about is an acute care residency appropriate? Does that count as a CVP residency? Can you still sit for the cardiovascular exam if you've done an acute care residency?
Morgan, I'm going to jump in on that one. So
Yeah,
no.
go for it.
So
Yeah.
acute care residency does not count. It has to be a cardiopulmonary clinical residency. But what does count if you've done an acute care residency is your number of hours. So you cannot fill out the application and just check the box option B, residency. You have to check the box A, which is 2,000 hours. So even though you've done an acute care residency, you have to demonstrate the hours for sitting for the exam, because acute care residency does not fit the need.
Okay. That's kind of what I thought. I think I did reply to that in the chat box somewhere, but thank you for clarifying. In terms of study strategies, there are a couple questions on study strategies. Do you have any recommendations for how to create a timeline for study? And how do you recommend to break down the longer cases in the actual exam items?
So Ellen and I both agree that 6 to 9 months is the appropriate timeline. And so if you're somebody who is a slow learner or a slow reader, then you're going to need more like 9 months. If you're somebody that is a faster reader and a quick study, then you're going to need 6 months. You want to do some kind of self-assessment tool so that you know where your weaknesses are. You can either do that by looking at the DSP and looking at the areas, or you can use the cardiovascular and pulmonary self-assessment tool. And so then that gives you an idea of your weaknesses. And those are the sections that you want to study. So a lot of people have said that pharmacology is one of their weaknesses. So you want to start reading the pharmacology chapter today. And then you need to start quizzing yourself. Every time you have a patient in the hospital setting that has a cardiovascular or pulmonary problem, look at the medications and quiz yourself. What's that one? What's that one do? What's that one do? What's that one do? And if there's one that you don't know, or you don't know if it's a cardiac or pulmonary medication, write it down, look it up that night. The more you review the things that you don't know, and the more you force yourself to do it in your daily clinical practice, the more it's gonna sit in your brain, okay? So that's one way that you can do it. You can also, if you decide you're going to take some continuing education courses, you can plot those on your calendar, and knowing that that month or that week of that month, you're going to get a really high intense dose of studying. If you haven't read the book, then break down the book and how long do you think it's going to take you to read this chapter. Some of the chapters are longer than others. And so, and some of it is more dense material, okay? And if it's a chapter that you're not as good at, like anatomy and physiology may be an easy read for you, but the pharmacology chapter may be a difficult read. And so maybe you take 1 week to read anatomy and physiology and 2 weeks to read pharmacology. But start looking at your calendar and breaking down the dates and seeing just how long it's going to take you to get through all of these things, including those other helpful textbook resources that we talked about.
And
any other suggestions?
Yeah, what I typically do with the meds, in addition to what you're saying, which is perfect, I also tell them to start grouping the meds. So
Yes.
if you have a patient with coronary artery disease and that's it, what are the typical medications you would see for a patient with coronary artery disease? And if they've come in with an MI, so we typically see beta blockers, lipid lowering drugs, and depending on their coronary disease procedure, they may be on platelet inhibitors or whatever. So you kind of get this little, relationship with the drugs to the disease. And so you start getting to understand, if you have a diagnosis of coronary disease or bypass surgery or whatever, what drugs you should be seeing. And when you're seeing additional drugs, then you're talking about additional comorbidities. And so what drugs do we see with diabetes? What are your typical drugs for heart failure? So I also tell them to study that way, and that helps also. And if they're more familiar with cardiac and not pulmonary, there are a lot less drugs with pulmonary.
I definitely had a lot of success, and I'm sort of a newer CCS. I just certified 2 years ago, and when I started to use the clinical clusters of the primary diagnoses and kind of how they look on a person, and then what kind of medication should I expect there. When I started to group them in context, it was really helpful. And then I would go through, like Morgan said, and just put them on a patient every time I saw a patient. And it really it was less overwhelming for me in particular that way. So I'm sure other people have different strategies. Let's see, there's a new question. Are there specific resources for clinical considerations? Let's see if I can interpret this.
I think they're asking a much more advanced question.
Yeah.
And
right.
that there's no evidence. So that is a clinical scenario. Some places don't allow more than 2 drips, et cetera.
Mm-hmm.
So no, your answer, Katie, would be no, there aren't specific resources because there's no specific evidence on that. It's more of a clinical consideration. I did want to go to have you had any international students sit?
Yeah, I was going to say.
I'm going to read this statement. Applicants must hold a current, permanent, unrestricted license to practice PT in the U.S. or any of its possessions or territories. So you can only sit if you have that license to practice PT in the US or its possessions or territories.
And then there's a question on obtaining a W-2. No, when you look at how they ask for your hours, how they're going to verify the hours that you worked is by calling your boss. So on that line where you say how many percentage of your time, how much percentage of your time was with cardiovascular and pulmonary patients, it'll say please enter your, supervisor's name and their email address and phone number, and they will contact them. Mm-hmm. So make sure your supervisor knows that they will be contacted.
Mia, yeah, the slides, I did email the slides to everyone this morning who had registered by at least the end of the day yesterday. I can send them out again. If you would just leave your emails in the chat box, I'll copy those down and send slides after we're done here. I think, are there any other last minute questions? We've covered a lot. We've covered everything.
Well, I'm going to say thank you, everybody, for listening to us for an hour and a half going through all this. We hope that this helps you. We want you to have resources. We want you to be able to be successful. We want to see the number of CCSs more than higher than some of the others. And we think that cardiopulmonary clinical specialists are needed, particularly as we advance through COVID-19 and beyond, new, diseases, et cetera. We want to raise the level of the profession. And so Morgan and I are we're totally, bought into helping people. And that's the reason that we do this. We beg the cardio section to let us do this all the time.
And we appreciate you all doing it. And thank you all so much for joining us this evening. This is recorded, like I said in the beginning. I'll edit out the front side a little bit, and it'll be posted probably to our all of the social media. And I think that's it. So if you all have any more,
we can also see if we can put it on the website.
Yep, we can definitely do that.
Oh, I would like to say there are some resources that the cardiovascular and pulmonary section has put out in case you have not heard of these resources that have been going around. The cardiovascular and pulmonary section has put out a ton of resources specifically for COVID. And if you go to our website, thecardiopt.org, and click on the COVID-19 specific dropdown, you will be sent to a page that lists all, there's this thing called the PACER Project. There's 18 lectures in that series. They are all online webinars. They are all free. And some of them are going to be helpful for this test. Keep in mind that it is a COVID slant to the lecture, and as Ellen said, because COVID is 2020, it will not be on your 2021 test. But like Ellen gave a great lecture on vitals. I gave one on cardiopulmonary examination. There was one from Annie Downs on airway clearance techniques, et cetera, et cetera, et cetera. So those are going to be very helpful to you. And so, don't forget about that resource as well.
Well, I'm also going to tell you, Morgan, all you have to do is Google PACER, P-A-C-E-R, and it immediately goes to cardiovascular and pulmonary section PACER project. And it has all of them listed that are up right now. I think there's only 13 or 14 up at the moment. And it's hysterical that it's #1 on your Google search. So I was so excited.
There have been thousands of people watching these webinars. And so
from across the globe. Don't forget that.
Kenya,
people from
Saudi
everywhere.
Arabia, Ireland. We've heard from a lot of people.
Afghanistan.
Yeah.
So yeah.
So anyway.
Yeah, I agree. Those are actually great resources, or a place to start for your study, so that you can get yourself sort of familiar with what you feel comfortable with and what you really need to spend a little bit more time on.
And I did want to say, for the person who did or maybe is doing an acute care residency, I am sorry that you can't sit. People have tried to petition the specialty council, but they do allow you to sit if you have the hours. So it may be just another 6 more months before you have enough hours if you're an acute care resident. I do apologize that that can't happen, but they have to be strict. These were the restrictions that were placed. But that said, thank you guys.
Yes, thank you very much. Again, email us. I'm Talia Pollok, and I'm the education person. You can get my email address from the CVP section website. If you have any more questions about resources related to this evening, just let me know, and I will get them to the right person. So thank you all. Thank you, Morgan and Ellen.
You're welcome.
You're welcome.
You're welcome.
We're glad to do it.
Have a great night, everyone.
Good night.